Good morning, everyone. Today I'll be talking on diagnosis and management of AKI in patients with cirrhosis, a nephrologist's perspective. I'll be covering my talk under following headings, that is introduction, assessment of kidney function in cirrhosis, evaluation of AKI, etiology-driven management of AKI in cirrhosis, role of renal replacement therapy, ILBS data, and finally summary and future directions. Coming on to the introduction, there are various criteria for defining AKI, like the Rifle criteria, the Aiken criteria, but the latest is the KDIGO criteria. As per KDIGO, AKI should be diagnosed when a serum creatinine increases by more than equal to 0.3 milligram per deciliter within 48 hours, or is more than 50% from baseline within previous 7 days, or when the urine output is reduced below 0.5 ml per kg per hour for more than 6 hours. AKI in cirrhosis is common. The incidence of in-hospital AKI in patients with cirrhosis ranges from 20 to 50%, and its burden has increased approximately 200% since 2004. These trends are concerning as it leads to poor clinical outcome, and patients with AKI or AKI superimposed on chronic kidney disease have approximately 3 times greater mortality. Episodes of AKI have long-term effects on patients with cirrhosis, leading to acute kidney disease, and also more likely to develop CKD, and patients who are CKD are more prone to develop acute kidney disease. The emergence of NAFLD has greater susceptibility and decreased physiological reserve to recover from AKI. Now, how do we do the assessment of kidney function in cirrhosis? Estimating GFR utilizing serum creatinine-based formulas are usually incorrect because serum creatinine concentration is affected by decreased hepatic synthesis of creatine and loss of skeletal muscle in cirrhotics. So serum creatinine is inherently lower, and GFR is often greater than the measured GFR. So equations combining creatinine and cystatin C are being more often used nowadays. Evaluation of AKI in cirrhosis, physical history and physical examination remains the cornerstones. Complete urine analysis with microscopic examination of the urinary sediments are the essential elements. Kidney ultrasound is routinely done to rule out obstructive uropathy as a cause of acute kidney injury. Urinary biomarkers have been tested to assess AKI in cirrhosis, and these includes NGAL, that is neutrophil gelatinase associated lipocalin, liver fatty acid binding protein, kidney injury molecule, tissue inhibitor of metalloproteinase, and several other markers are coming up. As we can see, NGAL, interleukin 18, kidney injury molecule 1, and liver fatty acid binding protein are all tubular markers, and these markers help in differentiation of ATN from pre-renal and hepatorenal syndrome. These days, NGAL is mostly used, and most of the studies show that this has the greatest sensitivity. And other markers like microRNA 21 and microRNA 210, these are also being used, but these haven't got FDA approval, and the role is greater in sepsis-associated AKI. As we can see in this figure, basically pre-renal azotemia, which is essentially functional AKI, where the patient will have great increase in the serum creatinine, but the urinary markers will be, urinary cell injury markers would not be present. Whereas in ATN, we can see there is structural, that's a structural, essentially a structural AKI, where the urinary cell markers would be present. So NGAL can actually helps us differentiate between the type of AKI, and it also detects subclinical AKI. So it has a very good upcoming role. Etiology of AKI in cirrhosis, as we can see in this figure, pre-renal AKI, which are the causes are laxatives, which are given for hepatic encephalopathy, diuretics for ascites, decreased intake, hepatocardiorenal syndrome type 1, renal vein congestion due to abdominal compartment syndrome, portopulmonary hypertension, and cirrhotic cardiomyopathy. Acute GN, which involves the kidney, that HCV-associated MPGN, hepatitis B associated GN, and IgA nephropathy, which is the most common glomerulonephritis in cirrhotic patients. Toxic ATN, which could be due to cholemic, fluoroquinolones, drug-induced fluoroquinolone given for SBP, vancomycin. Then ischemic ATN due to prolonged pre-renal hemorrhagic shock and septic shock. Interstitial nephritis, drugs like fluoroquinolone, penicillins, and proton pump inhibitors, which are actually very commonly used, can have the potential to cause interstitial nephritis. Obstructive uropathy, midodrine is one drug which is actually has the potential to cause obstructive uropathy. Now coming on to the etiology-driven management of AKI in cirrhotics. Pre-renal azotemia accounts for 15 to 30% of AKI in patients with cirrhosis. In a study done by Wong P.Y. et al., pre-renal azotemia secondary to GI hemorrhage was the most common cause of AKI in cirrhotics, accounting for 69% of the cases. Factors leading to volume depletion includes diarrhea due to laxatives, GI hemorrhage in esophageal varices, urinary losses due to diuretics, and poor oral intakes in context infections such as SBP. What actually happens here is it's basically there's a combination of peripheral vasodilatory state along with poor effective arterial blood volume and hypoalbuminemia, which actually predisposes these patients to a pre-renal insult. So, and cardiorenal syndrome 1, along with renal vein congestion and intra-abdominal hypertension. From 10 ascites are the conditions that actually contribute to the spectrum of the pre-renal causes in AKI in such patients. So we have to be careful in managing these patients. The evolution of advanced cirrhosis typically leads to a state of high cardiac output failure, and patients are at the risk of developing cirrhotic cardiomyopathy. In this figure, we can see the pathophysiology of AKI in pre-renal AKI. These are these factors. They're systemic factors and intrarenal factors. The intrarenal factors, we know the NSAIDs and ACE-ARBs. These are the most common drugs which actually alter the renal hemodynamics, causing decreased renal perfusion and thus leading to decrease in the GFR. What happens here in the systemic factors, basically when the oncotic pressure goes down due to hypoalbuminemia, there is increase in the interstitial fluid and due to decreased intake, loss in the form of hemorrhage, GI bleed, or if there is a decrease in the central venous return in diseases, pulmonary diseases, increased abdominal pressure, all these things leads to basically decrease in the blood volume, which further decreases the effective arterial blood volume. And along with the decrease in the cardiac output in conditions where in the congestive cardiac failure, the overall intrarenal factors along with the systemic factors play a role in exacerbating the pre-renal AKI. Approach to volume management in patients with cirrhosis and acute kidney injury. As we can see in this diagram, there is basically, we have to maintain a balance between the fluid overload and basically hypovolemia. So in these conditions, whenever there is a GI bleed, laxative use, infections, large volume paracentesis, or when patient is getting diuretics, these leads to basically a hypovolemic state. So in these conditions, we have to appropriately give them fluids. And whereas conditions like cardiomyopathy, portopulmonary hypertension, hydrothorax, abdominal compartment syndrome, these are the conditions where basically patient will have hypervolemia. So we have to be very careful in managing them, and we can try giving them diuretics. So there has to be a balance between the hypovolemia and hypervolemia in these patients. Regardless of the etiology or severity, the treatment is centered on volume resuscitation. Intravascular assessment is often complex. A trial period of 24 to 48 hours of targeted volume resuscitation with albumin has been recommended. Routine administration of volume expanders without knowing the volume status might pose a risk for pulmonary edema. So a combination of history, physical examination, and point-of-care ultrasound optimizes volume status assessment. In a single-centered retrospective study in patients who were diagnosed with HRS-1, focus-based assessment led to reclassification of AKI etiology according to the inferior vena cava diameter and collapsibility. 21% of the patients who were previously deemed clinically euvolemic were actually hypovolemic, and 23% of the patients who were actually were presumed to be hypovolemic were actually had adequate volume resuscitation. So diagnostic utility of point-of-care ultrasound in this setting should be emphasized. Proper fluid management in AKI is extremely important. It is like a double-edged sword. Extreme negative and positive fluid balance is a strong risk factor for AKI non-recovery. Correction of intravascular hypovolemia is a key component of the prevention and management of acute kidney injury. Clinical assessment of fluid status, as we can see, we can clinically and on physical examination, we can see how we can assess the fluid status. There would be decreased lacrimation, dry mucosa, neck veins, engorgement and fluid overload, additional heart sounds, that is S3 gallop in patients who are fluid overloaded, and capillary refill time, pulse pressure. All these are clinically how we can assess that patient is in fluid overload. So basically, the relationship between the hydration status and complications in AKI injury is a U-shaped curve, which is like a very narrow fluid, where we can actually see that there is a chance when we are giving we are adopting liberal fluid protocols, patient can actually go into fluid overload, and that can actually further complicate the issue, and patient can develop renal failure and renal dysfunction, organ congestion. This is the pathological sequel of fluid overload in organ systems. We can see state of fluid overload is actually deleterious for all the organs. It can actually lead to increase in the renal venous pressure, renal interstitial edema, further which can actually reduce the renal blood flow. Then further there will be reduced GFR, and thus patient will land up into advanced uremia. We divide the, how do we actually manage pre-renal? The first step we take is withdrawal of the offending agents. As we have discussed in the pathophysiology, NSAIDs are notorious for conferring a greater risk for AKI in patients with cirrhosis. The use of laxatives and diuretic medications must be carefully evaluated. Excessive GI fluid or urine losses. ACE, ARBs, as we discussed, it alters the renal hemodynamics and further reduces the GFR. Beta blockers, which is used in portal hypertension, increase the risk of development of HRS by reducing the systemic arterial pressure. So they should be discontinued in patients with cirrhosis who have AKI. Volume expansion, the second step is the volume expansion for hypovolemia. IV volume expansion is the cornerstone for treatment of hypovolemia. In cirrhotic patients, albumin is more effective in restoring the effective arterial blood volume as compared to crystalloids. So, in patients with SPP, co-administration of albumin with antibiotics led to a greater reduction in the incidence of AKI as compared to placebo added to antibiotics. So in the light of considerable benefits of albumin, the International Club of Ascites recommends albumin-based volume expansion at the dose of 1 gram per kg for 48 hours as an initial strategy to revert hypovolemia in cirrhotics with AKI. Emerging reports suggest that the liberal fluid approach may not be ideal. In our cities, comparing, this was a very large trial which was ATTIRE, administration of albumin was actually associated with greater risk of pulmonary edema and no survival benefit. Then there was another large trial, phase 3 trial, confirmed trial. Patients who were treated with terlipressin and albumin had a greater incidence of respiratory failure. Non-invasive modalities such as point-of-care echocardiography, lung ultrasound, and other methodologies like VEXIS may prove useful to guide volume management in this patient population. Nonetheless, a time-limited trial of tailored albumin resuscitation is a reasonable approach if the clinical picture suggests a pre-renal state. And for patients arriving with GI hemorrhage, volume resuscitation with blood products should be done. Identification and ligation of underlying bleeding vessels intended to minimize the blood loss should be pursued in active GI hemorrhage, leading to hemodynamic instability. The third step we follow for pre-renal AKI is decongestion. That is, decompensated cirrhosis with portal hypertension leads to ascites, which in turn can lead to intra-abdominal hypertension and abdominal compartment syndrome. Elevated renal venous pressures impair renal perfusion, and that can further cause or exacerbate pre-renal AKI. Renal vein congestion is not rare in advanced cirrhosis. In a study by Prem Kumar M. et al., a cohort of 125 patients with cirrhosis, the central venous pressure was 12.8. In another study by Matsumoto and et al., a renal vein diameter of more than 12 mm was associated with greater mortality. And then there was another recent study which was done by Sitapati H. et al. In evaluating the impact of large volume paracentesis on kidney function among hospitalized patients with cirrhosis. Kidney function improved in 10% of patients after LVP, whereas it worsened in only 4%, supporting the role of decongestive therapies in patients with cirrhosis and intra-abdominal hypertension. As the disease progresses, there is decreased cardiac conductance and contractility, which leads to the progression to cardiac cirrhotic myopathy and cardiorenal syndrome type 1. Diuretics, along with in these conditions, along with the traditional heart failure medication, should be considered. Then the state of decompensated cirrhosis, portal hypertension, and deranged hemodynamics also predisposes this group of patients to develop portopulmonary hypertension. Portopulmonary hypertension could actually potentiate the right heart failure, intra-abdominal hypertension, and renal vein congestion, thus precipitating pre-renal AKI. Early administration of IV prostacyclin was associated with improved 5-year mortality, but however, its role in AKI has not been studied as far. Coming on to hepatorenal syndrome type 1, as we can see here, HRS-1 has been replaced by the term HRS-AKI, and HRS-2 has been replaced by the term HRS-AKD, wherein there would be decrease in the GFR of below 60 ml per minute for less than 3 months. And HRS-CKD is where GFR is less than 60 for more than equal to 3 months. HRS-1, which is like HRS-AKI, it's divided as per the KDIGO, stage 1, stage 2, and stage 3. Stage 1 is when the serum creatinine, as we've already discussed, when the creatinine actually rises from to more than 0.3 milligram per deciliter in 48 hours. Stage 1, and like when there is 50% increase in the creatinine in last 7 days, or when the urine output falls to less than 0.5 milligram per kg in more than 6 hours. Stage 2 is when it is more than equal to 2 to 2.9% of baseline, and stage 3 is when it is more than 3, or the creatinine is more than 4, or patient is dependent, is KRT dependent, that is needs kidney replacement therapy. The prerequisites are a patient is a case of decompensated cirrhosis. There is absence of shock. There is no history of treatment with any nephrotoxic agents. No response to volume expansion. Absence of any parenchymal disease, and suggestion of renal vasoconstriction with fractional excretion of sodium of less than 0.2%. So HRS is a unique form of AKI in patients with cirrhosis, portal hypertension, and ascites. Several risk factors have been identified as predictors of HRS, like higher baseline creatinine. It is said patients who have greater than creatinine, who have more than 5, they have that's a predictor of and non-reversibility of HRS. Lower systolic blood pressure, other hemodynamic parameters such as evolution of hepatocardiorenal derangements, and ACLF patients. These are this diagram shows the determinants of HRS-AKI reversal, as we can see, worsening hyperbilirubinemia, baseline CKD status, or if there is, the patient is cirrhotic having cirrhosis cardiomyopathy, these are poor determinants of AKI reversal. Whereas patients, when we remove the triggers, the improved status of acute and chronic liver failures, these are the conditions where there's a possibility of reversal of HRS-AKI. Norepinephrine and terlipressin are the most effective agents to treat HRS. Vasoconstrictors and albumin are the mainstay of HRS treatment and are recommended in guidelines by EASL, ASSLD and ACG. RCT suggests that midodrine and octreotide regimen is less effective in reversing HRS in comparison to terlipressin or norepinephrine. In the favorable scenario of HRS reversal, if the pathophysiological state that predisposed HRS is still present, HRS recurrence may ensue and retreatment should be pursued. Now coming on to cholemic nephropathy, which is also referred to as cholemic nephrosis, cholemic nephropathy or bile cast nephropathy. In patients with hyperbilirubinemia, it refers to condition which is characterized by intratubular bile cast with impaired kidney function in the setting of cholestasis. Epithelial cell cast is described in the patients with severe hyperalbuminemia and suggests cholemic tubular injury. So this was like a recent evidence for cholemic tubulopathy. Whether tubular casts are actually causing the AKI or whether the high bilirubin is the cause. So there is supporting evidences and not supporting evidences in this regard. As we can see, the high serum bilirubin in HRS1, we know there is a decreased response to the vasoconstrictors, and in in patients who are having higher serum bilirubin, we can actually see that their kidney biopsies have more of tubular epithelial cell cast. Also, bile acids also increases the splanchnic vasodilation. Also, there is this evidence on these autopsies where bile-containing cast are prevalent in cirrhosis and AKI. Induced AKI, as we've already discussed, fluoroquinolones, antibiotics, and presence of sterile pyuria. In a patient, we should actually we should see, the clinician should actually keep in mind the possibility of AIN and should stop these drugs. Then glomerulonephritis, secondary IG nephropathy is the most common in these patients, with decompensated cirrhosis. And management is ACE, ARBs and proteinuria control. Recently, SGLT2 has also been given to retard the progression of CKD in such patients. And there are trials which are there, like DAPA CKD and EMPA kidney trials. Glomerulonephritis, hepatitis C, hepatitis B associated GN. They are, as we've discussed, they lead to MPGN, that is membranoproliferative GN. KDIGO and ASSLD, both the guidelines recommend directly acting viral agents for these patients. But patients who are having cryoglobulinemic flares, such patients should be actually given rituximab along with plasmapheresis. So, coming on to discuss then role of RRT. Basically, just want to summarize. This is how we should actually approach a patient who's in cirrhotics who are having AKI. Firstly, we've discussed it, that we should stop the offending drugs like NSAIDs, beta blockers, and RAS inhibitors. We should assess the volume by POCUS, and then we should go for a detailed history examination, and then actually rule out any hydronephrosis on ultrasound. And if there is, then we should go for a urology consult. If there are any dysmorphic RBCs, we should think of acute glomerulonephritis. We should go for a biopsy, then plan immunosuppression and antivirals depending upon the cause. If there is sterile pyuria, then we should see if there is any drug exposure and stop the offending drugs. So on urinary microscopy, if there are muddy brown cast along with urinary sodium of more than 20, then we should actually see if suspect that there is nephrotoxins because of toxic ATN. We should suspect this. And if there is a bland urinary sediment, urinary sodium of less than 20, and fractional excretions of sodium is also less than 0.2, then if we see that if there is history of any volume loss, and if there is no congestion by POCUS, then we should actually think it's a pre-renal azotemia and stop diuretics, give IV albumin and PRBC transfusion. If there is tense cystitis, we should go for large volume paracentesis. If there is cardiorenal syndrome, then we should actually give diuretics, or hepatocardiorenal syndrome type 1, we should consider giving them diuretics. HRS we have already discussed. And then assessing the response to intervention and prognosis to decide the eligibility for liver transplant. This was an ILBS data. Thank you, ma'am. Number of patients with septic associated AKI admitted in ICU were total 254. Mean age was 45.6. They were mostly males, 91%. Mean MELD was 27.3%. CTP score was 12.3. 43% were alcoholics and 44% were obese. 29% were diabetics. The median urinary NGAL was highly raised in such patients. That was 1865.5. AKI, most of them were in AKI stage 3. The cause of AKI was ATN in most of the patients, followed by HRS in 24%, and remaining had pre-renal volume responsive AKI. So out of these patients, 45% developed AKD at day 90. Who developed AKD had higher urinary spot sodium, urinary protein ratios were higher, NGAL was also high. Development of AKD was an independent predictor of 90-day mortality, which is actually in tune with all the studies which have been already quoted in literature. So summarizing it, the burden of kidney dysfunction in patients with cirrhosis is rising. AKI in patients with cirrhosis is not limited to HRS. The differential diagnosis includes other cirrhosis-specific and non-cirrhosis-specific causes. Management should be tailored according to the cause. Vasoconstrictor therapy is a specific treatment for HRS, and kidney replacement therapy should be offered to patients who fail medical therapy or are eligible for liver transplant or have a meaningful chance of kidney recovery or benefit from the intervention. Future directions, we need better definition of how much IV albumin and vasoconstrictors should be given, biomarkers which have a long way to go, and also a distinction between the type of AKI without kidney biopsy, predicting reversibility, irreversibility, initiation and stopping rules for RRT, transplantation, maintaining priority for liver transplant in patients who respond to pharmacological treatment of HRS, markers to identify patients who require SLK versus liver transplant alone, and development and validation of post-reported outcomes. Thank you.